First of all, I want to appreciate President Harap for giving us very precious opportunity. Our society CSRS AP was founded in 2010 as a sister society of CSRS and CSRS European section. As we are the youngest society, we have been struggling to catch up even a little in the history of about 12 years. As you know, more than 60% of the world population lives in Asia-Pacific region, and many patients are suffering from cervical spine diseases. Among them, there are many intractable cases involved. Today, we want to introduce 5 categories of intractable cervical disorder we have confronted in Asian countries. Our education committee selected 5 surgeons who are leaders to treat them in each country. First topic is infectious diseases in cervical spine, presented by Dr. Rajasekaran from India. Second is severe deformity, explained by Dr. Suk from South Korea. Third topic is hyperkinetic cervical spine, mainly in athetoid cerebral palsy patients. I am in charge of this topic. Next intractable disorder is drop head syndrome. As the aging society advanced, this disease is increasing in Asian countries, including Japan. Then Dr. Ishii will present it. Last topic is tumors, including of metastasis at cervical spine. China, the world's most populous country, is actively working to treat very difficult tumors in cervical spine. Dr. Feng Wei from China is a speaker of this topic. As you know, cervical spine locates between head and heart and play an important role as a human lifeline. Therefore, we cannot run away from intractable cervical disorders. That is the reason I pick up them of CSRS AP 2023 as cervical spine between head and heart. If you are interested in our struggles and experience, please join the next our meeting in Yokohama, Japan. Let's move on next topic. The second topic is severe deformity, provided by Dr. Kyung-Soo Suk. Please start your lecture.
I'm Kyung-Soo Suk from Korea. Thank you for the invitation. I will talk about severe deformity. The term severe deformity is a very subjective topic. Therefore, it's better to say cervical kyphosis. Cervical kyphosis can be classified depending on the shape, causes, or flexibility. But the classification depending on the flexibility is more important than the other classification because we can treat it depending on the flexibility. We can perform anterior surgery, posterior surgery, or AP combined surgery. Anterior surgery can provide anterior release, support, and good root decompression, but relatively poor stability and hard to get multi-level cord decompression, whereas posterior surgery provides better stability and easy to get multi-level cord decompression. But most biggest disadvantage is high risk of iatrogenic foraminal stenosis. If we perform AP combined surgery and we can get both advantages of anterior and posterior surgery. Therefore, I prefer AP combined surgery. Let's see the cases. Fixed kyphosis. This lady shows old healed draining sinus. And here we can see severe kyphosis at CT junction and cord compression and syrinx formation. This is from C6 to T5 was fused as one piece of bone, and that's due to sequelae of TB spondylitis. I perform AP combined surgery. After the surgery, the patient can walk. This lady shows also kyphosis at CT junction. T7, T1, 2, 3 bone was fused as one piece of bone and sharp bony beak compress the spinal cord. Here we can see the sharp bony beak. Usually we perform corpectomy in this kind of patient, but I believe that just to remove this portion of bone is enough for this patient. Therefore, I use a PSO technique. After C7 pedicle subtraction, I perform this cancellation and decompression. After the surgery, this sharp bony beak was completely removed, and 1-year follow-up CT scan shows very good healing without any bony beak. Fixed kyphosis, we can treat it, corpectomy or PSO. Let's see the rigid cases. Adult onset Still's disease patient has very kyphosis with a subaxial subluxation. I perform PAP surgery. After the surgery, sagittal alignment improved and cervical lordosis was restored. And cord was completely relieved. Chin on chest deformity. C2 slope, nearly vertical. C12 subluxation. Odontoid process fracture with non-union. C3, 4, 5 facet was fused. Many problems in this patient, but the most biggest obstacle for the surgery is severe osteoporosis. I perform skull traction and skull fixation from C1 to T2 and intraarticular bone graft at C12 and T4-5 facet was released and 2-level anterior release and support and posterior through the surgery. Here we can see the C12 intraarticular bone graft. Cord alignment was improved. The patient escaped from chin and chest deformity, 2-year follow-up, solid fusion. Even though odontoid process was not fused, C1 intraarticular bone graft was fused. Therefore, there's no C1 instability. This lady showed very severe kyphosis, the malnutrition, and end-stage renal disease, motor zero, sensory was nearly zero, but partially preserved. C2 slope nearly vertical with nearly 100% displaced anteriorly. Here we can see very severe kyphosis. C5, 6 vertebral body fused with kyphotic posture. I perform AP combined surgery, and the sagittal alignment improved, and spinal cord alignment was also improved. Swan neck deformity. This 14-year-old boy with a 45 degree of kyphosis with a rigid curve. I perform AP combined surgery. After the surgery, cord alignment improved, sagittal alignment improved, and entire spinal alignment was also improved. Very severe kyphosis. Here we can see the skin, alveolar spot, duraeptasia with tiny bone. This is neurofibromatosis type 1. Here we can see very tiny bone, very small vertebral body, very thin pedicle, very thin lamina, very small lateral mass. I perform skull traction and anterior surgery and posterior surgery. After the surgery, sagittal alignment was improved, and spinal cord alignment was improved. 2-year follow-up, solid fusion was accomplished, and entire spinal alignment was improved. Take-home message: fixed kyphosis, we can treat it. Corpectomy, PSO. Rigid kyphosis, I prefer to AP, combined surgery, or PAP surgery. Sometimes in severe cases, skull traction is helpful. Thank you.
Thank you, Dr. Suk. Any questions from audience?
Dr. Suk, can I ask?
Yes.
So I just worry in case of severe kyphosis, especially rigid kyphosis, I just worry about the aspiration pneumonia after correction surgery. Do you always do video fluoroscopic examination of swallowing?
Not always. But when we make increased lordosis and it's a high risk of swallowing difficulty, and long surgery is also the risk factor. So in that cases, I delay to oral intake about 3 to 5 days, because the peak swelling of the prevertebral soft tissue is about 2 or 3 days. So in that cases, I delay oral intake.
Okay, thank you.
Thank you.
Thank you.
Thank you very much. Okay. So I have one message. So when we confront the very tough case, we should observe and take very carefully examine the patient neurological condition. And after that, when we perform the surgery, we should keep original structures as much as possible and make reconstruction using such original structures. That is my most important message to you. So thank you for listening this session. So we enjoyed discussion. Thank you. Thank you, the lecturers. Thank you all.
Thank you.
Thank you very much.
Thank you.